Greeting everyone. My name is Vladislav Zhmakin, and today I want to talk to you about the pathologic intra-abdominal air. So first and foremost, these are the main steps of my presentation. So as you can see, I'm going to start with the objectives, then I'm going to make a brief review about how the normal things are going. Then I'm going to talk to you about the pathologies, and I'm going to finish with some take-home points. So these are four objectives or things that I want to explain during my presentation, if you will. So first one is to differentiate between normal and pathologic intra-abdominal air. Basically, because how can we know if this is a pathological intra-abdominal air without knowing what's normal? Then to identify main modalities used to diagnose pathologic intra-abdominal air, to identify main radiologic signs of each condition, and to provide differential diagnosis. Well, I think the anatomy is the key for everything and the basis for everything. And with this picture of axial picture of the abdomen, I wanted to show where the peritoneal cavity is, because I think it's important to at least understand where the cavity is, because it would help us to find free air in it. So here I've highlighted the peritoneal cavity in red. On this slide, there are three images. There are three abdominal plain films. On each of them, there are different bowel gas patterns. For example, on the left side, on the left image, there is a stomach gas or air in the stomach, small bowel gas and a large bowel gas. On the central image, there is mainly presented large colon gas pattern, and on the right image, there is mainly small bowel gas pattern. On these two images and these two images are here to help us understand what small bowel gas pattern and large bowel gas pattern look like. So on the left image, there is a so-called valvular connivance. These are specific sign of small bowel gas pattern. So look at this valvular connivance. They are crossing the lumen of the bowel completely, and also they are pretty close to each other in comparison with large bowel on the right image, where the haustral folds, they do not cross the whole bowel lumen, and they more widely apart, spaced more widely apart from each other in comparison with the valvular connivance. So going back to the pathology, to the pneumoperitoneum, these are the main causes of pneumoperitoneum. And I think it's vital to know that the pneumoperitoneum could be a sign of hollow viscous perforation. And it is for that reason, I think in our minds, we associate the pneumoperitoneum with some type of emergency or even urgency surgical intervention. But I think it's extremely important to know also that in some cases, we do expect to find and to see free air in the abdominal cavity. So let's say a patient underwent an abdominal intervention, a laparoscopy or a laparotomy. So today, or at least less than 7 days ago. So to see free air in the abdominal cavity of that patient is completely normal. But two things we want to make sure about this patient. First, the air should be decreasing on each follow-up image each day. And the second one is we should make sure that after 7 days of post-operative period, there would be no free air in the abdominal cavity. So only 7 days. Another causes of pneumoperitoneum could be pneumothorax and pneumomediastinum. Iatrogenic pneumoperitoneum could be as a consequence of, for example, drainage placement or leprosynthesis. Vaginal aspiration could be the cause, for example, as and since the female's abdominal cavity is connected with outer world via the reproductive organs. So the douching or the postpartum exercises or even excessive squatting could be the case. On this slide, these are two radiographs. On the left, there is a radiograph of the chest, and on the right, there is a radiograph of the abdomen, and both of them show cupola sign, so-called a rim of blackness just beneath the diaphragm. So this is a free air in the abdominal cavity, and here also. And basically, the air tends to go to the highest point in the cavity. So if the patient stands or sits upright, the air goes to these places, I say. If the patient is unable to stand or sit upright, we should consider a view of the abdomen with the patient in the left lateral decubitis position. And in this case, air would go also to the highest point in the abdomen, so pushing a lever downward. And in case of pneumoperitonitis, we would see something like this: air fluid level above the liver and below the abdominal wall. And on the left, there is a normal image. So there are many signs specific to the pneumoperitoneum. I was trying to find and to choose the most interesting and maybe practical. And before explaining the next sign, we should understand the mechanics, I think. So on any plain radiograph, if we can see different objects and distinguish them, there should be the density pretty big density gradient on the border between two objects. So for example, on chest X-ray, we can clearly see the ribs margins because the air surrounds the ribs margins, and the air has low density and ribs has high density. And because of this density gradient, we can see margins. The same thing is seen in the abdomen. For example, look at this right scheme. In normal state, gas or air present only within the bowel lumen. So the gradient density is big only on the inner side of the bowel wall, because a gas has low density, bowel wall has high density. But there is no high density gradient on the outer side, because bowel wall density and peritoneal fat density are almost the same. But in case of pneumoperitonitis, when we have gas on either side of the bowel wall, we can clearly see both sides of bowel wall, and it makes the regular sign. So for example, on the left image, we can here clearly see both bowel wall sides, because there is free air outside and air inside the bowel wall. And right images with the hint just helps us to find the finding. Another sign needs a little bit of words before. So falciform ligament, I want to remind that falciform ligament goes from the anterior surface of the liver, as also on this axial CT scan, from the liver to the anterior abdominal wall. And that's why we see so-called silver sign or falciform ligament sign on the abdominal plane when the falciform is surrounded by free air. So falciform has high density, air has low density. That's why we see the falciform ligament. And this is a diagrammatic representation of what we should see here. Another sign is football sign. Well, this is a composition of three things. First of all, it's the distended abdominal cavity, like a ball for football or rugby. The second one is falciform ligament sign over there, and urachus, also seen. So urachus and falciform ligament looks like this suture on the football. And this picture is helps us understand how the urachus and the median umbilical ligament goes from the dome of the bowel to the umbilical ring. Going to CT, and CT is much more sensitive and specific in terms of diagnosis of pneumoperitonitis. And so, in some cases, the diagnosis is obvious because there are a large amount of air in abdominal cavity. In other cases, there is small amount of air in abdominal cavity. So on plain radiograph, it could be undetected. Another views of CT of the abdominal cavity, axial CT with a pneumoperitoneum. So sometimes a long window is used to facilitate search for the free air, as in this example. You may remember that image. So this is an axial CT of the same patient. Here you can see also ligament, falciform ligament going from the anterior abdominal wall to the anterior surface of the liver. Ultrasound is also used in diagnosis of the pneumoperitonitis. So on the left image, you can see peritoneum and no evidence of free air. On the right image, you can see also peritoneum, but also you can see beneath the peritoneum an enhanced stripe sign and comet tail or artifacts due to air in ultrasound image. So enhanced stripe and reverberation artifacts. It's so hard to pronounce. And these are also in other ultrasound images showing free air and comet tails. So there is a question: is there any images, at least one image with evidence of free air? And the question is no. So first one, as you remember, it is Chilaiditi sign. So Chilaiditi sign is just interposition of normal colon loop. So it presents between right hemidiaphragm and liver. And this is a CT axial image, shows again normal colonic loop with haustral folds. And also with the meticulous look, you can see the presence of haustral folds on chest X-ray. Another one cases of so-called pseudo pneumoperitoneum are the combination of irregularity and elevation of right hemidiaphragm and lower zone consolidation and linear basilar atelectasis. These two mimic pneumoperitoneum also, but in reality there is no free air. And also sometimes distended and overlying bowel loops can mimic regular sign, but in reality there is no free air. Going to Pneumoretroperitoneum, again, I'm going to show anatomy, and I'm going to highlight the retroperitoneum space, not cavity. It's very important with red. And it's important why? Because in cavity, there is no resistance to air for movement, but in space filled with fat and the retroperitoneal organs, air is locked. So it's difficult for the air to move. So the causes of pneumoretroperitoneum are hollow viscous perforation again of the organ that has strong connection with retroperitoneum space, for example, duodenum, ascending, descending colon, or lower rectum, or cases of postoperative, especially urologic or spinal surgery, pneumoretroperitoneum. Okay, on this slide on the right, there is a diagrammatic representation of how should look, or how looks pneumoretroperitoneum with margins of kidneys surrounded by air. And on these two plain films, on the left, there is without hint abdominal radiograph where you can see air surrounding kidneys. And here with the hint, there is air in green. Again, air in the retroperitoneal space, and an axial CT confirming this air in the retroperitoneal space. These two images are here to demonstrate how much air could be in retroperitoneal space, so around kidney and also in retroperitoneal space beyond. And here are two images showing that usually the air patterns are linear in retroperitoneal space in case of Pneumoretroperitoneum. So linear stripes around the retroperitoneal space organs, and here also. Ultrasound, or so-called the veiled right kidney sign, veiled or obscured right kidney sign, was seen first in very thin person, and was described as unusual difficulty in finding of the right kidney. So as you can see on the left image, there is lots of artifacts and air hyperechoic signals, but very veiled and obscured kidney. And over here also lots of air hyperechoic signals and and very obscured kidney. Another images of ultrasound, again comet tails, hyperechoic signals, and evidence of air around kidney, so-called blurred kidney. And here is the image of ultrasound with so-called small curtain, small amount of air anterior to the aorta. So again, the question is there at least one image with a Pneumoretroperitoneum? And the answer again is no, because on the left there is a pretty much and moderate amount of air in subcutaneous tissue and between muscles. So it mimics the Pneumoretroperitoneum. And on the right, there is a air fluid level projected over the liver, which is just the a hepatic abscess. Again, free air? Nope. On the left, there is a small amount of air in the right kidney parenchyma. So it is a case of emphysematous pyelonephritis. And here, one small amount of air here and here in right kidney and in the inferior vena cava. And finally, Pneumobilia. On the right, there is a magnetic resonance cholangiopancreatography, or MRCP, of normal anatomy of the biliary tree. So we can see gallbladder, cystic duct, common hepatic duct, common bile duct, etc. And this is a diagrammatic representation of how Pneumobilia looks like. The etiology is there, and there are several causes. The most common is recent biliary instrumentation, especially after ERCP. Also incompetent sphincter of Oddi, especially with increased intraduodenum pressure. Other causes are biliary enterics, surgical anastomosis, spontaneous fistula, for example, in Mirizi syndrome, and infectious processes. So these are two plain films showing on the left tree-like lucency projected over the right upper quadrant, and on the right with the hint there is air in blue, and also cylindric metallic density projected over the lumbar spine. This is a patent stent, and it's interesting that in some articles, in some studies, they decrease when the air in the biliary system disappears or decreases in amount. It's called a sign of stent obstruction. So if we see the decreasement of air amount in the biliary system, we should think about stent obstruction. CT images, very important to look for the location of this free air, maybe not free air, but abnormal location of air. So two reasons of location for air here. First of all, air tends to spread upwards, and lower lobe is higher than right lobe. And also, it is central due to centripetal flow of the bile. So bile goes from the periphery to the central, and that's why air in the bile ducts tends to be in the central parts of the liver. The same thing here is here. Ultrasound is used in diagnosing of pneumobilia, and this one is demonstrating hyperechoic signal within biliary system, within distinct shadowing, which is consistent with pneumobilia, and the same is here. This is an image of pneumobilia on MRCP with the evidence of air in the biliary differential and the dilatation of common bile duct. And finally, differential diagnosis of pneumobilia. There are at least two conditions that we should think about when we provide the differential diagnosis. First of all, it's the portal venous air. So look at this diagrammatic representation first. With small amount of air, it should look like that. So air located in the periphery of the liver, because portal blood goes from the central to the periphery, so-called centrifugal blood flow. So not in the central like pneumobilia, but on the periphery. If the amount of air is large, then we would see air everywhere. So on the plain films, you can see tree-like lucency over the right upper quadrant, left upper quadrant, and with the hint in the hepatic branches of portal vein and in the splenic vein. Again, on CT, axial image of CT with of the patient with portal venous air. Again, air tends to go upwards in the lower lobe, but periphery, the peripheral parts of the liver, so due to the centrifugal flow of the portal blood. And if there is a large amount of air, we would see something like this. Again, so let's call it a face-to-face comparison. Pneumobilia central location, portal venous gas peripheral location. Again, diagrammatic representation here helps us to understand. And there is a mnemonic where C in common bile duct gas stands for central, and P in portal venous gas stands for periphery. And sometimes pneumobilia should be differentiated with gallstones. I know that X-rays and CTs are probably better in differentiating, but if we see something like this on T2 weighted axial MRI, we cannot know whether it is air or stone. So we should use T1 weighted gradient echo in face axial image, and on that image, on this image, we can clearly see that this is a stone and this is air. And now I want to emphasize on a couple of points. So regarding pneumoperitoneum, I think it's always important to check clinical history, but in case of pneumoperitoneum, it's especially important because sometimes we do expect to see air in the abdominal cavity. And if there is an uncertainty on X-ray film, you should go either for the patient position change or for CT. And regarding Pneumoretroperitoneum, CT is the most specific to diagnose this condition and to rule out other conditions mimicking the Pneumoretroperitoneum. And as I said, it's retroperitoneal space, not cavity. So if we compare pneumoperitoneum and pneumoretroperitoneum, just try to change the position of the patient. If gas moves, then it's probably cavity. It's probably a gas in the cavity, so it's probably pneumoperitoneum, not pneumoretroperitoneum. And regarding pneumobilia and portal venous gas, I put here just a mnemonic, even though I'm not the big fan of mnemonics, and I decided to remember just the mechanism that bile goes from the periphery to the center, and venous blood flow from the center to the periphery. And at that point, I want to just say thank you for your time and for your attention. Thank you.